Good afternoon, everyone, and welcome to Foundation Frontiers, a new medical education series hosted by Foundation Medicine. I'm Jen Mills, the Vice President of Medical Affairs at FMI, and I'm joined by an incredible cadre of speakers, whom I'll introduce more in a moment. But first, in the spirit of true disclosure and transparency, our disclosures. Let's see if we can maybe advance 2 slides. And the next slide. Amazing. This session is sponsored by Foundation Medicine, and you see additional respective disclosures here, as well as our personal employment and financial disclosures on the next slide. And with that, allow me to introduce you to our first speaker, my friend and colleague, Dr. Neil Fischbach. Dr. Fischbach is a board-certified medical oncologist and assistant professor of clinical medicine at the Yale Cancer Center. He also serves as the assistant director for clinical research, where he's responsible for overseeing research efforts among Yale's 15 care center networks, with the goal of increasing clinical trial availability and enrollment for all patients across the network. Dr. Fischbach has done some amazing work identifying patients in real time for trials. His personal research interests lie in precision oncology with a focus in breast cancer. Passionate about delivering equitable care for all, Dr. Fischbach also serves as the Chief Medical Officer of the Thrive Cooperative Center for Wellness, a new cancer survivorship organization affiliated with the Smilow Cancer Center at Yale. I'm also so honored to introduce you to Dr. Mia Levy, who serves as Foundation Medicine's Chief Medical Officer and brings nearly 2 decades of clinical expertise as a medical oncologist specializing in breast cancer. Dr. Levy is also a nationally recognized expert and leader in both precision medicine and biomedical informatics. Prior to joining FMI, Dr. Levy served in dual roles as the director of the Cancer Center Network at Rush University Medical Center and as the vice president of cancer services at Rush. Prior to her tenure at Rush, she was at Vanderbilt University, where she served as associate professor of cancer research, associate professor of bioinformatics and medicine, and the director of the Cancer Health Informatics and Strategy team. Among her many contributions to the field, Dr. Levy also led the development of My Cancer Genome, an international knowledge resource for patients and physicians alike. And with that, I'll turn it over to Dr. Fischbach to walk us through an overview of the state of the field and some perspectives on biopsy. Thank you, Neil.
Thanks, Jen. And it's a real pleasure and honor to be with you all today. To start, anyone who is wondering whether we have arrived in the era of precision medicine, this slide really proves that we are. There is an exponential growth in targeted therapies that are arising from our exponential increase in understanding of mechanisms of growth and survival of cancer cells. And with each integration of a new targeted therapy comes discovery of new resistance mechanisms. And with discovery of new resistance mechanisms come new targeted therapies to overcome those resistant mechanisms. So when I see this slide, the first thing I'm entirely grateful for is that I am a breast medical oncologist and I can focus in the upper right of this slide rather than having to focus on the whole thing. Just the utmost respect and admiration I have for people practicing general medical oncology. And the second thing I think when I look at this slide is it's really imperative if we want to be delivering highest quality medicine for our patients that we have a reliable company that we are very confident in, a source to get this precision medicine and comprehensive genomic profiling performed. So if we could move on to the next slide. Thankfully today, we are not talking about the entire world of oncology. We are focusing on metastatic breast cancer and specifically metastatic estrogen receptor positive HER2 negative breast cancer, which comprises about 70% of all metastatic breast cancer cases. And while we've been layering in new targeted therapies, general themes in treatment remain the same. If I could have the next slide. Generally, first-line therapy is hormone therapy with now a CDK4/6 inhibitor. And we typically will move on to second and even a third line of endocrine therapy if the clinical situation allows, before transitioning ultimately into generally sequential single agent chemotherapy. And while we've introduced CDK4/6 inhibitors in our standard first line therapy, we now have alpelisib approved in second line setting for those with PI3 kinase mutations. But how does precision medicine fit in all this? Well, within the last year and a half, we have a couple of very prominent FDA approvals, which really, I think, make us think about what is the role of genomic profiling, when should we be doing it, and how often should we be doing it? So just back in November 2023, capivasertib was FDA approved in combination with fulvestrant. And that study, the biggest benefit was for folks who had mutations in the AKT pathway. That includes PIK3 kinase, as well as AKT1 and PTEN. But that study also included patients who had progressed within a year of their adjuvant endocrine therapy. And so potentially for even first-line therapy, this is important to know about mutations in this pathway. And similarly, in January 2023, elacestrant was approved for the second-line setting in patients with ESR1 mutations who'd had one line of endocrine therapy. And I tell you today, just in my first half day of clinic, I've already seen 2 people who had ESR1 mutations with their initial diagnosis of breast cancer. So we typically think of the incidence of ESR1 mutations as low, maybe about 10% in the first-line setting, but it's not zero. And both those people appropriately, as soon as that information was realized, have moved on to SERD therapy with their initial CDK4/6. So if I could have the next slide, please. The rapid evolution of new targeted therapies are really making us think about what's the optimal timing to start and how often should we be repeating profiling. And I know Dr. Levy is going to have more to say about that in a bit. We all feel, I think, the same kind of intimidation about CGP. When do we do it? How often do we do it? What are the barriers? And there are many barriers, some of them as simple as administrative barriers, difficulty ordering the test, locating the results, EMR integration, and workflows. Also, as Dr. Levy will probably spend some time talking about later, the time barrier is important in thinking about CGP. And I think that we are all evolving to situations where we need urgent results for our genomic profiling of simultaneously sending liquid and while we're arranging for a biopsy to do tissue profiling. And I know that many in the audience may have questions about some of these other barriers, and I'm sure we'll have time to address those in our Q&A period. If I could have the next slide. So we have these 2 options now for our genomic profiling, solid and liquid. Solid obviously is a bit more sensitive. Liquid is faster. And we're going to spend some time today talking about when is each appropriate and what are the pluses and minuses. For tissue-based genomic profiling, there are some real issues with specimen processing and quality. I think we're all used to expecting if someone's had their diagnosis made on a pleural effusion or acidic fluid, we may not have enough cells in that cell block to perform our tissue profiling. Similarly, with bone-only disease, that historically had been a really big problem in that the harsh acid decalcification procedures were tough on DNA, but not surprisingly, the pathologists are getting pretty savvy about this now, and with formic acid and EDTA, I've been impressed that much more frequently we're able to successfully obtain adequate DNA for tissue-based profiling. Next slide, please. So before we get to the why-fors and wherefores about when would liquid be better than solid and how to interpret, I think it's worth taking a step back and just thinking about, well, what is this ctDNA stuff? And it really is as simple as circulating tumor DNA is simply DNA that has been released from tumor cells, usually in the process of necrosis or apoptosis, and released directly into the bloodstream in exactly the same way that a healthy tissue can release DNA into the bloodstream. And remarkably, not only can we quantify the amount of circulating tumor DNA in the blood and the fraction of tumor DNA compared to normal DNA, but we can also perform genomic profiling on that DNA, bigger and bigger panels. As we'll talk about, this testing works best when there's plenty of DNA, tumor-related DNA in the blood. And the kinds of things that can affect that are just what type of tumor is it? Different tumors have different shedding rates, the bulk of disease, and things like what have been the most recent line of therapy. Now, move on to the next slide, please. So when should we be considering liquid biopsy? Um, Obviously, at the time of initial diagnosis, if we can't get adequate tissue from a solid tissue site, this is a perfect opportunity for liquid biopsy. And I will tell you, in my own experience, I have uncovered germline as well as somatic BRCA1 and 2 mutations from liquid profiling. I think there are many women who still don't have access to germline genetic testing at the time of their initial breast cancer diagnosis, or may be presenting with de novo disease, and talk about a impactful discovery. Their BRCA1 and 2 mutation. I think one anecdote illustrating that is I care for a couple of women who are disease-free more than 4 years out from first-line PARP inhibitor trials. So that can make a big difference. We can identify HER2 mutations, as we talked about before, AKT pathway alterations, which may lead us to think about CAPI in first-line setting, and pan-tumor markers. So every now and then we will get lucky and stumble upon a NTRK mutation. As disease progresses, I think this is one of the, obviously, the greatest opportunities for ctDNA, the opportunity to not only detect emerging resistant mutations like the BRCA1 and 2 reversion mutations, but really the ESR1 mutations, which in folks who've had multiple lines of endocrine therapy can be as prevalent as 50% or more of patients can develop the ESR1 mutations. And lastly, putting on my clinical trials hat, ctDNA and CGP in general have been really one of the key elements allowing us to identify patients for clinical trials. And I think we probably all have noticed in our practice, those of us who have access to phase 1 trial divisions, that we've seen this very interesting flip-flop. Phase 1 used to be last bastion of next chemo, which is not going to work. And now phase 1 really is the next therapy that is more likely to work than what we would ordinarily prescribe in our practice. So the only way we're identifying people for lots of these trials is through the use of CGP. So as we are getting on to next part of the talk, where Dr. Levy is going to walk us through some of the really important technical aspects of ctDNA, but maybe we can keep this clinical vignette in mind, which is ripped directly from the pages of Dr. Levy's clinical practice. And this is a case of a 61-year-old woman who, like many, as part of her initial treatment with a high-risk local disease, received neoadjuvant chemotherapy, surgery, radiation, adjuvant hormonal therapy, and unfortunately, ultimately recurred. Did have initial CGP on tissue, which did not turn up any actionable mutations. Moved on to receive first and second line hormonal therapy and first line chemotherapy with a hair sparing agent. And now, unfortunately, the setting of progression is considering what her treatments are and could resistance alterations or other findings on ctDNA help inform our treatment decisions. And with that intro that we'll keep in mind, Dr. Levy, I will turn it over to you, and thanks everybody for your attention.
Thank you so much, Dr. Fischbach, for that introduction. And I'd like to continue on with this theme of how Foundation Medicine is innovating in this liquid biopsy space for comprehensive genomic profiling in breast cancer. As you may be aware, Foundation Medicine has several assays on the market, 2 FDA-approved assays for solid tumors, one for tissue testing and one for liquid biopsy testing. Both of those assays have approximately 324 genes, can report out tumor mutation burden as well as MSI status, and have over 25 plus companion diagnostic indications, including the most recent capivasertib indication for tumors with PIK3CA, AKT1, or PTEN loss. In addition, there can be PD-L1 testing. There's also a Foundation One Tracker assay, which is a tissue-informed monitoring assay that can look serially in the setting of advanced disease for response to therapies, specifically in the immunotherapy setting, for which many of our triple-negative breast cancer patients are currently getting, as well as a hematologic panel. We really believe in high-quality testing at FMI, and to enable this experience for patients who have advanced cancer. We've now delivered over 1 million patient comprehensive genomic profiling reports. And the essential features is that we have this validated bioinformatics pipeline that really is optimized for detection of companion diagnostic biomarkers, specifically infusions and other challenging variant types such as deletions, of which PTEN loss is one, and we'll talk about that in a moment. But it's really important to understand that we've validated all of these companion diagnostics and demonstrated our ability to detect these alterations with significant rigor through multiple FDA approvals across multiple cancer types in both tissue and liquid. We are also able to deliver on innovative biomarkers, and we'll talk a little bit more about our newly developed ctDNA tumor fraction that helps inform decisions when you have a negative liquid biopsy results. This algorithm was recently updated in November of 2023. And finally, our transparent reporting, which our report highlights, make it much easier to interpret results, to be able to find from comprehensive genomic profiling both actionable alterations for therapy selection, as well as potential germline alterations and clonal hematopoiesis alterations. So what is Foundation Medicine's ctDNA tumor fraction, and why are we so excited about it? Well, ctDNA tumor fraction is an estimate of how much of the total cell-free DNA is tumor-derived. And as Dr. Fischbach was describing earlier, there are some tumors that have a high amount of circulating tumor DNA or high ctDNA tumor fraction, and others that are low shedders that have a low amount of ctDNA. And there's biological characteristics that help drive whether or not a tumor is going to be high shedding or low shedding in a particular moment of time in that patient's diagnosis and therapy. So for instance, having a later stage tumor tends to be of a higher disease burden, and they tend to shed more tumor DNA into the circulation. Likewise, metastatic disease tends to have higher shedding, and patients who are progressing on treatment are more likely to have shed than if you might have tested them earlier on with liquid biopsy in their disease course. In contrast, those who are low shedding tend to be earlier stage disease, may only have a local or locally advanced tumor, or may be responding well to treatment, and you're catching them at a low shed state where they're in a good response to therapy. And this is a dynamic feature that ctDNA does change over time and in response to therapy as well. We have developed our tumor fraction algorithm to basically say that if you have a tumor fraction greater than or equal to 1%, that we should be able to detect actionable alterations for that tumor type. But tumors across different solid tumor types shed at different rates. And what you see here is that tumors that are either in the orange, either of the two orange colors would be considered greater than 1% and high shedders. So small cell lung cancer is the highest shedding tumor type. And on the lowest end of that, you have thyroid cancers where, less than 20% will have detectable ctDNA at a high enough rate for profiling. Breast cancer sits somewhere in about the middle. About 50% of breast cancer cases in our database experience will have a tumor fraction greater than 1%, meaning that they'll be well positioned for detection of alterations in their tumor for treatment selection. But tumor fraction not only helps inform whether or not we can detect circulating tumor DNA, there's also some subtlety in the types of alterations that are detectable at different levels of tumor fraction. And so your typical alterations in breast cancer that are mutations like base substitutions or insertions or deletions, such as ESR1, PIK3CA, AKT, and PTEN mutations, can all be detected at very low levels of tumor fraction. However, PTEN loss, which is a gene deletion and a homozygous deletion, which occurs in about 5% of hormone receptor positive breast cancer patients, really requires a higher level amount of tumor fraction to be detectable, in the range of about 10% tumor fraction. And so using liquid alone in a case that might have a low tumor fraction, you may not be detecting all of the alterations that are clinically significant in a patient with breast cancer. So when you're making this consideration for which type of CGP testing to do, tissue or liquid, there's a couple things to think about with a breast cancer patient. First is access to the metastatic site for biopsy collection, the sensitivity for the specific alterations you're looking for, as well as the likelihood that this patient is going to have enough ctDNA shedding and a high enough tumor fraction to give you a confident yes or no answer. So we described this case of a patient who'd had, multiple lines of therapy, and it's often in the setting when a patient is first diagnosed with metastatic disease that they do have a tissue diagnosis available. And Dr. Fischbach mentioned, acidic fluid or pleural fluid that actually can be spun down, and we can actually at FMI still use that. Those spun down cells to do tissue-based testing. So it is possible to use even those alternative specimen types, and bone biopsies can be successful today, as Dr. Fischbach was saying. And what's important here is that in this first line setting, this patient population here at this first, prior to their first line hormone therapy, often is lower shedders of tumor fraction compared to at later lines of therapy. Only about 40% of patients at this time point will have a tumor fraction greater than 1%. In addition, PTEN loss is better detected on a tissue test. And so we do recommend that if tissue is available in this first line setting, to consider doing a tissue-based test for all of the reasons, and in particular for PTEN loss detection, which is best done on tissue. And as I mentioned, Foundation Medicine is the companion diagnostic for capivasertib in patients with AKT1, PIK3CA, and PTEN alterations. And that is about 50% of all breast cancer patients will have one of these alterations. So the ability to detect, those 5% PTEN losses is at about an additional 5% of cases is really important when you have a high prevalence of those alterations. So what about at progression? You have a patient who now has clinical progression and has had one line of hormone therapy, and you think that they would be eligible for a second line or greater of hormone therapy. Certainly, this is a moment where liquid biopsy is really appropriate. It's less invasive than getting a new tissue biopsy, and tumor shed is increasing at the time of disease progression. So whereas we found about 40% tumor fraction greater than 1% at diagnosis of metastatic disease, at progression, either second or third line setting, that goes up to 50%. And ESR1 mutations are also increasing at a significant frequency. So now you're getting up to about 37% of breast cancer, hormone receptor positive breast cancer patients who will have an ESR1 mutation detectable prior to second line or third line therapy. And Foundation One Medicine, Foundation One's liquid CDX test has a very high depth of coverage for ESR1 mutations. We bait across 324 genes with 500x coverage, but for select genes such as ESR1 mutation and others such as PIK3CA and AKT, we go down to 3000x coverage. And so it's really important to understand that we can detect ESR1 mutations in liquid biopsies at a very high degree of sensitivity. So let's get back to our patient case. This woman, 61 years old, who has had multiple lines of therapy, and we get a liquid biopsy on her to consider, is she eligible for capivasertib now that it's approved for use in the United States. And unfortunately, her liquid biopsy test showed that she was negative for ESR1, but her tumor fraction was low, meaning that she was still low shedding. So what do we do next? What would we consider if she has a negative ESR1 and she's highly, highly motivated to not lose her hair and avoid chemotherapy for as long as she can? What would she consider doing another biopsy of a new tissue specimen? And in fact, she was interested in moving forward with that. In these cases where what we call an indeterminate negative, where you have a low tumor ctDNA tumor fraction, it can inform your consideration for getting a new tissue biopsy. And we certainly see this as an opportunity for patients who are really motivated to get on another line of therapy in a shared decision-making model. So this patient, so when we think about this, you're going to get a certain fraction of patients who are going to have a driver positive alteration, irrespective of their tumor fraction being low. So you can have a low tumor fraction and still detect an ESR1 mutation because, as I said, we go down to such a high level of detection. But if it's driver negative, you don't find that alteration. If the tumor fraction is elevated, the likelihood that you're going to find something on tissue, doing a new tissue biopsy is low. So I consider that an informative negative, this high tumor fraction. And I wouldn't suggest my patient get a new biopsy, a new tissue biopsy in that setting. But if it's a low ctDNA tumor fraction, doing a confirmatory tissue test should be prioritized because it may detect additional alterations, and especially if the patient is highly motivated and for an alteration class that is very, very prevalent. So we got a new tissue biopsy on her, and it did reveal an ESR1 mutation. And she went on elacestrant as her next line of therapy. And she has been on that treatment for over 15 months now, after having progressed pretty quickly on first-line capecitabine just prior to this. So really shows the power of doing doing a reflex testing and the power of tumor fraction in this situation. So in summary, I think as you're considering how to use comprehensive genomic profiling in your patients with advanced breast cancer, consider tissue testing at the time of metastatic diagnosis if you have tissue available, because it is a more sensitive test for detecting some alterations such as PTEN deletions. And at the time of progression, really consider doing another CGP test because the rates of ESR1 mutations go up dramatically, and you may discover that that you have a new therapy you can offer these patients that wasn't available to you before. And finally, don't forget that if the ctDNA tumor fraction is low at the time of a disease progression biopsy, liquid biopsy, consider getting tissue testing for your patients if they're highly motivated to consider another line of endocrine therapy. So with that, I want to just acknowledge our FMI testing profiling, and I will stop sharing my screen and bring up all of the presenters and see if we have any questions from the audience.
Yes, thank you so much, Dr. Levy and Dr. Fischbach, for that incredible overview and deep dive into where we are today. I'm wondering, as we invite the audience to please put questions in the Q&A feature, I'm wondering if you can give some thoughts of where we're headed. Where do you think the field of testing and therapeutics is going to be 3, 5, 7 years from now? Dr. Fischbach, you want to go first?
Okay, I know Mia wanted to answer that. Well, so we didn't address today, but I think the obviously not necessarily elephant in the room is ctDNA as a prognostic and predictive marker. I think there's really a tremendous potential for that, and as well as just uncovering more and more biomarkers. And as I mentioned at the very beginning, getting into this next phase of resistance mutations and how are we going to target the resistance mutations. And I think there's a really endless potential for that.
Dr. Levy?
Jen, I'll just jump in. Thank you. And I'll also just add that there is a lot of clinical trials being done in the exact disease state that we just talked about today. So there's a number of other, more targeted PIK3CA inhibitors that are in development, additional oral SERDs to address the ESR1 mutant population, additional AKT pathway inhibitors as well. So there's more coming even in this specific space that we're in. I think we're going to see a number of new therapeutics that hopefully will have less toxicity, especially the rash and hyperglycemia toxicities that we see with some of these targeted therapeutics that are trying to be more targeted for this patient population. And I will also add, Foundation Medicine is soon to launch our new homologous recombination deficiency assay this summer, which also can bring another layer of biomarker for PARP inhibition in breast cancer that we're excited to see come into the future.
And both of you have hit on a really critical component of we can invest in all of this incredible innovation, but if we don't get it to patients and we don't make it accessible and easy to the average provider, we've created potentially more disparities. And I know we're all working collectively to address those. So I know we're over, and I want to thank both of you, Dr. Levy, Dr. Fischbach, for sharing your perspective with us. Thank you to the team that has supported today, and thank you to all of our participants. We look forward to seeing you on the next session, and feel free to reach out to us with any questions. Have a great day, everyone.
Thank you.
Thank you.